is me as a little girl in Victoria, BC. I always dreamed about traveling and exploring the world. So when I was 9 and I went to this movie, I knew what I wanted to be. So when I was 18, I packed my bags, I headed off across Europe, and I ended up in Israel on an archaeological dig. But dusting pottery shards in the hot sun for 8 hours a day wasn't the adventure I was looking for. So I went back home, worked a little more, saved some money, and this time I took off for Southeast Asia. I first of all went to India. I rode a motorcycle from the very top to the bottom. I walked across Borneo, and then I found myself in Nepal, working for a medical organization to bring in supplies and people to rural parts of the country where there was no medical assistance at all. It was there that I really found my passion for global health. I traveled a little bit more, and then I decided I should get serious. So I went home, finished high school, went to college, university, and eventually found myself in medical school at the University of Calgary. I did a residency in family and emergency medicine, and then headed off to Harvard to do a degree in public health. It was there that I found my people. I was lucky because not a lot of schools at the time had programs in humanitarian studies, but Harvard did. I was the second year through, and I really found my niche. Humanitarian assistance is provided to those in the initial phases of the impact of a disaster or conflict when they are most in need. It's the acute phase, so it usually lasts over 3 to 6 months, and it includes things like water and sanitation, health, food, shelter, security, that kind of thing. It's different than development, which is over months to years, and it usually involves the contribution to long-term financial improvement. Humanitarian assistance as we know it today was founded in 1859 by a young Swiss businessman named Henri Dunant. Henri Dunant found himself traveling between Italy and Switzerland on a business trip, and he happened upon the Battle of Solferino. He was staying in Solferino at the time, and this battle was going on between the French and the Austrians. The premise was that no quarter should be spared. That meant that even if a man was injured, he should be killed. The result was extraordinary violence, and 38,000 young men left dead and dying on the fields of Solferino. The women of the town went down to provide assistance because there was no humanitarian assistance at the time. And they said over and over, tutti fratelli, all are brothers. They didn't discriminate between sides. They provided assistance to everyone. Henri Dunant was so moved that he went home to Switzerland and he founded the Red Cross, Red Crescent movement. The Red Cross, Red Crescent movement is founded on the humanitarian principles of humanity, impartiality, neutrality, and independence. These principles guide humanitarian actions in conflict. They are what allow us to access populations most at need. Today, there are over 5,000 organizations who are involved in the acute phase of humanitarian response, and probably many more if you consider the mom and pop shops, the community-based organizations, frontline providers, UN agencies, academics, emergency medical teams, and the private sector. Humanitarian response evolved to be what we know it today, partly because of the end of the Cold War, when the superpowers collapsed and there was a power vacuum, and many conflicts erupted due to ethnic reasons and civil strife, especially in former Yugoslavia, Rwanda, and Somalia. July 14th, 1994, saw 1.2 million Hutus exit out of northern Rwanda and into the Congo, formerly known as Zaire. The magnitude of this crisis was unimaginable. Humanitarian organizations thought that there would be only 200,000 people who would migrate across the border. They grossly underestimated the numbers. That meant that supplies were scarce, children were separated from their families, security was a major issue because many of these people were former genocidaires, and one of the other main issues was water and shelter. What's interesting about Goma, which is the city around where these refugees found themselves, is that it's built on volcanic lava rock. So it's very difficult to build latrines and even to establish shelters such as these ones. That meant that those refugees that had the energy, that weren't too dehydrated or exhausted from their travels, had to go to Lake Kivu to drink, cook, and bathe. Now what's interesting about Lake Kivu is it's also volcanic, That means that it's methane-rich and it has a thermophile layer, meaning that all of the temperature of the lake is the same throughout. It's a perfect growing medium for Vibrio cholera. July 18th, 1994, 4 days after the refugees came into Goma, the first case of cholera was detected. This spread like wildfire, 10,000 cases a day, until pretty much every single refugee had contracted the disease. Only 200,000 people survived. On looking back, the humanitarian community said that much of this could have been avoided. Consequently, the SPHERE project was launched. The SPHERE project was a consultative process with 4,000 individuals, 400 organizations, and many others from around the world who came together to create the minimum standards, the standards that should be met when we're providing humanitarian response in the field, to improve the quality of response and also the accountability of the humanitarian system. I got involved in the humanitarian system right out of public health school when I went to Darfur and Chad on a project with Physicians for Human Rights to look at the destruction of livelihoods as a means to commit genocide using a scorch and burn policy by the government of Sudan. Shortly after, I went to Liberia, where I cluster sampled the country, looking at the health and mental health outcomes of the people post-conflict. My area of interest into child soldiers was nurtured there, of course, because a third of the population of Liberia was involved in direct combat, and of that third, a third of those were children. From there, I went to the Congo and Kenya, and my research into sexual gender-based violence was flourished and carried through until now. But let's just go back to Chad. When I was in Chad, I interviewed a lot of refugees, and I interviewed these refugees at different refugee camps. Now, I should mention that a refugee camp is managed by one organization. So different camps are managed by different organizations, meaning that they have different services. For example, some camps have better health care. Some camps had programs for sexual gender-based violence, but most didn't. Some had better lighting and easier access to fuel, so women wouldn't have to walk for miles under the threat of being raped. Some had better shelters, some had easier access to water, and so on. And also, some had better resources and supplies for the camps, and the host population actually was underserved. So these differences interested me, and I'll touch on that in just a little bit, but fast forward 5 years to Haiti. I've also found myself in Haiti after the 2010 earthquake. And again, the humanitarian community said that this was actually, the aid response was actually worse than the impact of the earthquake itself. Over 3,000 organizations, most of them emergency medical teams from North America, deployed into this emergency. Most of these aid organizations comprised of individuals who are under the age of 30, and for the most part, it was their first time in humanitarian response. They had had no training, they had no idea about prioritization, and they had no idea what they were doing in the field. Colleagues of mine said that they saw resident physicians, so physicians in training, doing field amputations with no antibiotics and no anesthetic. People literally were dragging themselves out of their tent, trying to escape this horror. We know that the main airstrip in Port-au-Prince was clogged with private jets that had chefs to serve the emergency medical team members, and so that the main supply trail of planes, CF-18s and so forth, could not land. And UN peacekeepers brought in cholera into a country that had never had cholera before, further devastating the population. The report by the World Health Organization and the Interagency Standing Committee that was released after this said there was a gross oversight in terms of the deployment of aid workers and coordination on the ground. Medical tourism is a thing of the past, and it should happen no more. In 2017, there was 128 million people in need of humanitarian assistance in 33 countries across the world. The United Nations Office for the Coordination of Humanitarian Affairs launched the biggest appeal ever for $22.2 billion. People are on the move. There's more people on the move since World War II. This isn't just because of economics. This is because of wars, ongoing wars in the DRC, Iraq, Syria, Yemen. It's also due to famine in places like Nigeria, again Yemen, Somalia, Sudan. Not only that, but we know from climate change data, and even what's going on right now, that this is becoming a more important problem, creating more refugees. In fact, in 2016, the number of people affected far eclipsed the number in the previous decade. In 2016, 570 million people were affected, compared to 224 million people in 2006. The economic cost was $154 billion. There can be no doubt that we need humanitarian aid workers. As I mentioned before, there is at least 5,000 organizations worldwide. They operate in what is called the 7th biggest sector in the world, estimated at over $1 trillion a year. We know from data that there might be upwards of 20 million people who are involved in some way in humanitarian response, as volunteers, as frontline providers. But a study back in 2008, and really the only one available, shows that, or suggested that, there was 500,000 full-time humanitarian workers in the sector at that time. They suggested that this is growing at about 6% a year, which I think is grossly underestimated. But if we do the math, that puts us at about 850,000 full-time, so career professional humanitarians in the world today that are assisting in all sorts of conditions that are very complex and different to their own. My point is that these people need to have a knowledge base that's different to what they already know. For example, as a doctor working in Montreal, I can't assume that my skill set and what I know to practice medicine here is going to be transferable to working in a place like Chad or Haiti. I need to have a competency or knowledge base that is specific to working in humanitarian emergencies. And over the years, we know from the sphere standards to today that this is increasingly being informed by evidence and science and practice. We need to know things like the technical sectors of humanitarian response: water, shelter and sanitation, food, nutrition, hygiene, and so on. We also need to know about the principles of humanitarian response. We need to know about international law, codes of conduct, the actors, the system. We need to know about security and how to negotiate access. We need to know about leadership, management, grant writing, and how to manage ourselves in a stressful environment. These are all humanitarian competencies that we must know to practice in the field. Did you know that from January to March of this year, there was 149 attacks on humanitarian health care, and that in those attacks, 221 humanitarians died? In Syria, since 2014, there's been 678 attacks against healthcare installations. In 2017, there was 158 attacks on major aid operations. My point is that humanitarians need to have security as a competency. They can't just go in the field. Again, they cannot be disaster tourists. There's too much at stake. The implication is that humanitarians need to look at themselves from a professional standpoint. Oxford Dictionary defines professionalism as a professional quality, character, or conduct, and as a professional, a person who does something with a high level of competence, commitment, or expertise. My argument is that humanitarians are professionals. To support this vision, I started an organization called Humanitarian U. You know, you can't be a professional without some sort of professional development, training, like we have in medical school, for example. Humanitarians need the same. They need competency-based, standardized training. They need a system where they can have professional development, networking, and a community. And that's what Humanitarian U offers. So for the last 7 years, I've been working to provide those opportunities to humanitarians around the world. Now, as an aside, up till now, humanitarian training has been largely ad hoc. People can't normally afford to go to North America and attend an expensive university. And those who can, it's not clear how they get their first experience, get their foot in the door. You know, when I was in Uganda a number of years ago, I remember the logistician for this particular organization, who was in charge of organizing all the operations and negotiating access in Gulu and Kitgum. Just months before, he was a pizza delivery boy in North Carolina. A peer of mine from public health school told me that the reason he came back to public health school was because he saw himself overseeing a refugee camp for 20,000 people in Liberia and had no idea what he was doing, yet all of these people's lives were hanging in his hands. So as I mentioned, Humanitarian U has been working to provide this kind of training and education, like for my peer in public health school. But not just that. Over the last 2 years, we've been working with two partners, the Humanitarian Leadership Academy and MEDAIR, to look at the impact of professional training in the field. So not only on the humanitarians themselves, but on the people that really matter, the reason why we're doing this, the beneficiaries. Now you can imagine this is not an easy task. In fact, nobody had ever done this before. I mean, how do you come up with metrics or tools to measure the impact of work in the field when so much else is going on and you can't just isolate it on its own? But we did. So using mixed methods, we created a set of tools and metrics to look at what ways professional training actually makes a difference in terms of coordination and service delivery. This very innovative study had very good results. In fact, I'll just discuss some of these here. We showed that training provides a direct increase in knowledge and skills with practical applications. It strengthens competencies. It increases confidence and leadership skills. There's increased job effectiveness. People are better able to handle their roles. There's an improved ability to develop working relationships with stakeholders. There's an improved quality of work and a 25% job promotion rate. People have strengthened feelings of personal well-being, and there's a positive impact at the community level. I'd like to illustrate the impact that this training has had on beneficiaries by telling you a little story or providing you a quote from one of the health workers with MEDAIR. After she took the training, in fact, their whole team took training, we conducted focus groups with the beneficiaries to assess what their primary needs were. Our team now responds to these, and the beneficiaries are now well informed. In return, my team is also better informed, and there is a lot more community involvement and feedback. There's a continuous monitoring process throughout the project cycle. I think that we were really able to strengthen our approach to beneficiary involvement and the relations as a result of the training. We have received beneficiary feedback, and it is very positive. They feel that their voices are being heard. It has improved the relationships, communication, and ultimately the services with the beneficiaries. That's just looking at one kind of training. We'd like to look at more. So my story doesn't really end here. I think that the point is, and I'm hoping you can all appreciate, that we need better, more competent, and well-trained humanitarians. The world needs this because we're just going to see an increase in humanitarian need. But it's not just up to the humanitarians, it's also up to the organizations that employ them and the donor agencies that fund the projects in the field. Organizations need to better support these people. Right now, only 1% of annual budgets is spent on training. This is not enough. We need to prioritize this so we can provide better and more effective response. Donors need to look at this from their perspective as well and implement this into their request for proposals. And you need to become better informed. We all do. You know, I bet most people don't even know where Yemen is on the map, but I bet most people know who Cristiano Ronaldo is. Do you know that he is set to make 30 million euros this year? And before he's moved to Juventus, his contract with Real Madrid had him making $50 million for the next 3 years up to his 36th birthday. His lifetime sponsorship contract with Nike is valued at over $1 billion. Right now, the funding gap for Yemen is $100 million, desperately needed to save 22.2 million lives. So where are our priorities? So let's all work to make quality humanitarian response better and professionalize the sector. And I'll leave it up to you to think about how you might get further involved. Thank you.